Here is a detailed explanation of asthma. 1. Introduction. Asthma is a chronic inflammatory disease of the respiratory tract that results in airway hyperresponsiveness and reversible airway obstruction. It affects individuals of all ages and is characterized by recurrent episodes of wheezing, shortness of breath, chest tightness, and coughing. These symptoms vary over time and in intensity and are often triggered by various environmental and internal factors. Asthma remains a major public health problem due to its global prevalence and burden on healthcare systems. 2. Definition. Asthma is defined as a chronic inflammatory disorder of the airways, in which many cells and cellular elements play a role, particularly mast cells, eosinophils, T lymphocytes, macrophages, neutrophils, and epithelial cells. This inflammation causes recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, especially at night or in the early morning. These episodes are usually associated with widespread but variable airflow obstruction that is often reversible, either spontaneously or with treatment. 3. Etymology. The word asthma derives from the ancient Greek term asthma, meaning panting, or gasping for breath. The name reflects the characteristic breathing difficulty that defines the condition. The term was first used in medical literature by Hippocrates around 400 BC. 4. Epidemiology. Prevalence. Asthma affects over 300 million people globally and is one of the most common chronic diseases in children. Global burden. Approximately 250,000 deaths per year, mostly preventable with appropriate treatment. Age distribution. Onset usually occurs in childhood, but adult-onset asthma is increasingly recognized. Geographic distribution. Higher prevalence in developed countries, but increasing in low and middle-income countries due to urbanization and pollution. Gender. In children, more common in boys. In adults, more prevalent in women. Economic impact. Asthma contributes to loss of school workdays, emergency visits, and high healthcare costs. Have 5 types of asthma. 1. Allergic extrinsic asthma, triggered by allergens, dust, pollen, mold, pets, often associated with a history of eczema or hay fever. 2. Non-allergic intrinsic asthma, triggered by infections, stress, cold air, or exercise. No identifiable allergen. 3. Exercise-induced asthma, EIA, triggered by physical exertion, often occurs shortly after exercise. 4. Occupational asthma, caused by exposure to specific substances in the workplace, e.g. chemicals, dust. 5. Nocturnal asthma. Symptoms worsen at night, may relate to circadian rhythm of lung function. 6. Aspirin-induced asthma, associated with sensitivity to aspirin and other NSAIDs, often with nasal polyps. 6. Causes. Genetic predisposition, family history of asthma or atopy, environmental allergens, dust mites, animal dander, pollen, air pollutants, smoke, industrial emissions, vehicle exhaust, viral respiratory infections, especially in early life, occupational exposure, e.g. chemicals, flour dust, cleaning agents, exercise, especially in cold, dry air, emotional stress, weather changes, especially cold air, medications, NSAIDs, beta blockers. 7. Risk factors, family history of asthma, eczema, or allergic rhinitis, exposure to tobacco smoke, obesity, low birth weight or premature birth, early exposure to allergens, urban living conditions, occupational exposures, frequent respiratory infections in childhood, poor air quality or environmental pollution. Complications, status asthmaticus, life-threatening severe asthma exacerbation, chronic obstructive pulmonary disease COPD. In long-standing cases, respiratory failure, frequent hospital admissions and ER visits, reduced quality of life and limitations in physical activity, side effects from long-term medication use, e.g. steroids, pneumonia, and other respiratory infections. 9. Pathophysiology, step-by-step process. 1. Trigger exposure. Allergens or irritants initiate the inflammatory response in genetically predisposed individuals. 2. Immune system activation. Antigen-presenting cells activate T helper 2, Th2 cells, leading to the release of cytokines IL-4, IL-5, IL-13. 3. Mast cell degranulation. Mast cells release histamine, leukotrienes, prostaglandins, causing vasodilation and bronchoconstriction. 4. Eosinophilic inflammation. Eosinophils infiltrate the airway and release toxic granules, worsening inflammation and tissue damage. 5. Bronchoconstriction. Smooth muscle in bronchi contracts, narrowing the airways. 6. Mucus hypersecretion. Goblet cells increase mucus production, leading to airway plugging. 7. Airway edema. Increased capillary permeability leads to fluid accumulation and swelling. 8. Airway remodeling, chronic asthma. Long-standing inflammation leads to thickening of airway walls, fibrosis, and permanent structural changes. 10. Signs and symptoms. Wheezing, whistling sound during breathing. Shortness of breath. Chest tightness or pressure. Coughing, especially at night or early morning. Increased respiratory rate, tachypnea. Fatigue, use of accessory muscles to breathe. Difficulty talking during an attack. 11. Diagnosis. Clinical history, pattern of symptoms, triggers, family history. Physical examination. Spirometry, decreased FEV1-FEC ratio 70%. Bronchodilator response, improvement in FEV1 after salbutamol. Peak expiratory flow rate, FR, diurnal variation or response to treatment. Methacillin challenge test, provocation test for airway hyperresponsiveness. Chest x-ray, usually normal but used to rule out other conditions. Allergy testing, skin prick or IgE blood testing. 12. Nursing diagnosis, ineffective airway clearance related to bronchospasm and mucus production. Impaired gas exchange related to airway inflammation. Activity intolerance related to fatigue and shortness of breath. Anxiety related to difficulty breathing. Deficient knowledge regarding disease process and management. NOS 13. Medical management, rescue medications. Short-acting beta agonists, a buzz, e.g. albuterol. Anticholinergics, e.g. ipratropium maintenance medications. Inhaled corticosteroids, ICS, e.g. budesonide, fluticasone. Long-acting beta agonists, LAs, e.g. salmeterol. Leukotriene receptor agonists, montelukast. Mast cell stabilizers, cromolyn sodium, theophylline, rarely used. Biologics, omalizumab, mepolizumab for severe allergic asthma. Systemic corticosteroids for severe exacerbations. HAF 14. Nursing management. Monitor vital signs and respiratory status. Administer oxygen and medications as prescribed. Position patient in high Fowlers to ease breathing. Educate on proper inhaler use with a spacer. Teach peak flow monitoring and symptom tracking. Encourage fluid intake to thin mucus. Promote rest and reduce anxiety. Identify and advise on avoiding triggers. TAF 15 treatment options. Pharmacological, inhalers, ICS. Oral medications, montelukast, corticosteroids. Biologics, in severe cases. Non-pharmacological, breathing exercises, pursed lip, diaphragmatic breathing. Yoga and relaxation therapy. Pulmonary rehabilitation. Emergency interventions. Oxygen therapy. Intravenous corticosteroids, intubation, and mechanical ventilation in severe attacks. 16. 5 psychosocial interventions. 1. Cognitive behavioral therapy, CBT, helps reduce stress and anxiety, which are known asthma triggers. 2. Support groups allow patients to share experiences and coping strategies. 3. Asthma self-management education teaches patients to monitor symptoms, use inhalers correctly, and follow action plans. 4. School-based interventions helps children manage asthma effectively in school settings. 5. Family counseling supports caregivers and ensures they understand asthma care. 17. Prevention. Avoid exposure to known allergens and irritants. Use HEPA filters and keep indoor air clean. Get annual flu and pneumonia vaccinations. Avoid smoking and secondhand smoke. Treat respiratory infections promptly. Maintain a healthy weight. Adhere to prescribed asthma medications and follow action plans. A18 Conclusion. Asthma is a widespread chronic inflammatory disease of the airways with significant health impacts. With early diagnosis, appropriate medication, lifestyle changes, and education, asthma can be effectively controlled. A multidisciplinary approach involving healthcare providers, patients, and families is essential in minimizing symptoms, preventing exacerbations, and improving quality of life. Thank you. Have a nice day.